Hello, everyone. I'm Dr. Tony Dance, and I'm here with you today to talk about health information systems and how they affect governance of universal healthcare. The objectives of my talk are to highlight elements of governance needed for implementation of universal healthcare. Ano ba ang mga kailangang pagtugunan ng pansin para ma-implement ang universal healthcare? And number two, to demonstrate how the health information system supports these elements of governance. Let me start with some definitions. Electronic health records are the electronic charts used by our doctors, nurses, and midwives when they see patients. When you connect these electronic health records to other databases, such as those of the pharmacy, the laboratory, the radiology lab, or the financing system, it's called a health information system. So the outline of my talk is to discuss the rationale of the Universal Healthcare Law, or Republic Act 11223, very briefly, and then point out issues in UHC governance, the issues that are important to implement universal healthcare. I'll spend more time on number 3, which is describing the role of the health information system in implementing universal healthcare. So let's start with the rationale of the Universal Healthcare Law. The ongoing pandemic has exposed a lot of flaws in our healthcare system. I'm sure you know a lot of people who developed cough and colds and didn't know where to go. Would they go straight to a specialist, a lung specialist, or an infectious disease specialist? Or could they see a GP? Or maybe they could go straight to a laboratory or pharmacy and get some medications. Many end up lining up in hospitals, and that's exactly what happened. We filled up our hospitals not just with cases of severe COVID, but even mild COVID flooded to occupy bed space. So this exposes many problems in our health system. First, it's an uncoordinated system. Kanya-kanya tayong hanap ng mag-aalaga sa atin. Tayong bahala kung saang ospital pupunta, saang pharmacy or laboratory. It's specialty focused. When we have a headache, we want to see a neurologist. When we have chest pain, we want to see a cardiologist. And it's hospital-centric. We pay for diseases during hospitalization, but we don't pay for the outpatient services needed to prevent these diseases in the first place. Now, the Universal Healthcare Law tries to address this. We aren't there yet, but there are many potential solutions. For example, the UHC law mandates formation of the healthcare provider networks, beginning from primary care to the laboratories and pharmacies, the specialists, and various levels of hospitals. It's no longer specialty focused. It mandates the provision of a primary care provider for every Filipino. These are the people at the bottom of this graph, the doctors, nurses, midwives, GPs, family physicians, internists, who provide first contact care to our patients. Ibig sabihin, sila yung unang pinupuntahan. At sila ang tagapag-alaga ng karamihan ng mga karamdaman na pwedeng ikonsulta ng ating mga pasyente. Third, it mandates payments for outpatient services through PhilHealth. So we are all looking forward to a consulta package in the coming months or years. A fourth provision, which is very important, is something that connects all these facilities and services, the health information system. Without this, there's really no network, and we can't really say that we improve healthcare, because our patients' records in the clinics must be connected to the pharmacy and laboratory. It must be connected to the specialists, and if patients get admitted, hospitals must have access to these records. This is impossible without a health information system. So what are the issues in governance that we need to address to implement UHC? Well, the first is the health information system. As I pointed out, it needs to connect all the facilities and personnel in the healthcare system. We also have to address workforce development. Kulang ang ating healthcare workers, and we need to improve the number of healthcare workers that can be accessed by our patients. Number three, we need to establish the healthcare provider network, no? Partnership to of the different facilities in a province or city, or even in a certain private facility. We also need to address financing and decide what to pay for and what not to pay for. And we need to engage our community. We need to let them know what to expect when they finally decide to utilize the healthcare services. Finally, we need to determine our performance measures. How do we know that the health system is performing well or underperforming? This will help us decide what improvements need to be taken. One thing we realized in the Philippine primary care studies is that the health information system plays a crucial role in all the other 5 elements of governance. So the health information system will help us develop the workforce. It can help us develop the healthcare provider network. It can help us make decisions on financing policies. And it can help us engage our community and monitor our performance measures. So it plays a crucial role. It's like the cog in the wheel that puts everything together. So what are the ways that the health information system can do this? Well, first, let's focus on workforce development. These are our 3 sites. Our urban site in UP Diliman has 15,000 community members. Our rural site in Samal Bataan has 38,000 community members. And our remote site, our GIDA, is Bulusan, Sorsogon, with 28,000 community members. Our urban site in UP Diliman had 11 primary care doctors and 10 specialists. In contrast, our rural and remote site had only 1 doctor each. And most of the healthcare was provided by an army of nurses, midwives, and barangay health workers. We had to gradually increase the number of doctors until we felt that workflow was optimal. This meant adding 3 primary care doctors in Samal and 2 primary care doctors in Bulusan. So it seems the ideal or optimal ratio of primary care physicians to population was around 1:10,000. It's much better in other countries, but it's the least we can target when we try to implement universal health care. So one thing the health information system helped us do was keep track of the number of healthcare workers. In this hypothetical map, it could mean coming up with a list of primary care providers, nurses, midwives, internists, pediatricians, family physicians, and GPs, and even specialists like gastroenterologists and cardiologists, coming up with the list and mapping them out in our locality so that we know where they are and we can identify gaps in the number of healthcare workers that we provide our populations. Another way that the health information system helped our healthcare workforce development was in training. This was training, continuing professional development for skilled healthcare workers such as doctors, nurses, and midwives, but also included continuing education for our barangay health workers. Continuing training is a big problem. First, this entails a lot of funds. Second, it takes time. So healthcare workers need to leave their posts to attend these training seminars. Third, there's just too much information to remember. And if you wanted to carry the manuals that they distribute, it's just too bulky to carry around. So this guy in the middle, in the figure below, carrying a cell phone, had the right idea in mind. No? Digital learning platforms or decision support systems. The one we decided to use in our study sites was an application called UpToDate. No? It provides evidence-based information that's constantly updated several times a day, providing excellent information for healthcare providers in various areas. It costs about $300 a year per user, but in our study sites, we were able to get it for free using their donor program. And in general, there are many advantages of these digital decision support systems. First, they come in a condensed format. They can fit in your phone or in your laptop. Therefore, they're portable and you can carry them around. And this allows healthcare workers to learn on the go while they are seeing patients. It's also useful where there are few doctors because it can give non-physician healthcare workers access to information that they may need to take care of patients. And it also assures better spending. It can help healthcare providers ensure that their money is better spent by the healthcare workers. This is a workshop we held in Bulusan, Sorsogon a few years ago, where we taught the barangay health workers how to use UpToDate. So we taught them how to use Google Translate so that they could share the information with their patients. They only had access to a lay portal. We didn't want to turn them into doctors where they could treat and diagnose. But at the very least, they should have access to information that patients should know about their conditions. In this way, they were helping the few physicians that they had in their communities. So the health information system helped workforce development by developing a map of health human resources and by providing a portal for continuing training and education. Now let's go to the healthcare provider network. These are our 3 sites again. In our urban site, we had a fairly large laboratory and pharmacy in the campus of UP Diliman. In contrast, in Samal and in Bulusan, the laboratories were very small and provided a very limited number of tests. The pharmacies as well carried very few medications, mostly the medications that were given free by the Department of Health. This meant that in developing our healthcare provider network, we had to link with private pharmacies and laboratories in our study sites, especially in Samal and Bulusan. So that's an added benefit of the health information system. We had a list of facilities, hospitals, private clinics, public clinics, pharmacies, laboratories, and radiology labs, and we were able to map them out. Again, helping us plan our healthcare provider network. So, the HIS helps through a facility inventory and through the development of a map. How does it help financing? Well, the budget for our 3 sites was the same, 300 pesos per capita per year in each of our communities. We offered a comprehensive outpatient benefit package, which meant we paid for any test or any medicine that the patient might need. We, however, had a spending cap. Beyond 2,000 pesos, the patient had to pay out of pocket. We think this is important. While many people believe that we should cover for everything, we think that patients should be allowed to pay some fees out of pocket so that they bear some of the responsibility in taking care of their own health. One of the differences was in our remote area. There were many isolated barangays in Bulusan, Sorsogon, and so we had to cover for health-related transportation. And this was very important in improving access to the benefits that we were providing. So as you can see, by linking the charts to the financing system, we were able to monitor consults, labs, and medication expenses on a monthly basis in our urban, our rural, and our remote site. In addition, we were able to monitor transportation expenses, and as you can see here, encircled in red, in some months, we spent as much as 50,000 for transportation. Napakarami ho talagang mga pasyente na kung hindi nyo bibigyan ng pamasahe, hindi makakapunta sa ating rural health units. Another benefit of the financing system, linkage, was monitoring expenses. We found, for example, that on the 3rd month of the pandemic, there was an unusual spike in the purchase of vitamins in one RHU. So as much as 160,000 pesos in just 1 month. And we traced this to fake knowledge or fake information that vitamins could help treat or prevent COVID-19. We had to disseminate information that this was not true, that this was fake news, and we had to curtail spending of vitamins for a few weeks to be able to quickly control this overuse of vitamins during that period. So, linking with a financing system, the health information system allows us to monitor expenses. It also allowed us to pay efficiently. Alam namin kaagad kung magkano ang babayaran at kung sino-sino. And this was very important, especially in our remote site. The pharmacies and laboratories were very small, and if you delayed payment by as much as a month, they would fold up. It also helped us control abuse of certain privileges, as you saw. And we didn't have the opportunity to do this, but it could potentially help us control any attempts at fraud. Now we go to the health information system and community engagement. In the study, we developed posters on primary care and brochures that we could distribute. We also had videos. We had patient testimonials and endorsements by influentials. We had animated videos on what is primary care and why we need primary care. May English, may Tagalog version. And we were able to share these various media at workshops or town hall meetings. We also placed them at the waiting rooms of the various clinics. One important benefit of the health information system is access to patient contact numbers. And this is very important because SMS is one of the most widely available forms of communication in the country. And it could be a venue for disseminating warnings on disasters, on pandemics or epidemics, or invitations to health programs of the LGU. So, through the health information system, we could store our posters, pamphlets, and videos. In addition, we had access to contact numbers, which may be used for healthcare needs. And then performance measures. This is one of the first things we had to address. We thought of different measures we could use. We could use what the Millennium Development Goals often coaxes us to monitor, like infant mortality, death from malaria, increasing tuberculosis cases cured with DOTS. We did very well in various areas in 2016 when these development goals were being monitored. But when you look at outcomes that apply across diseases, no, hindi lang sila malaria, TB, or infant mortality, for example, unattended deaths, we fail. Up to 60% of deaths were unattended in the year 2016. That means 60% of people who die have no access to a healthcare worker for the condition that they died of. No? So we thought we should abandon these vertical measures of performance and look for horizontal measures that apply to any disease rather than to specific diseases. For example, healthcare needs of the poor. Are they being attended? This will apply to infant mortality, malaria, or tuberculosis. Is there equitable access to healthcare services? Are there educational material to improve health? And are essential medications affordable? This will apply horizontally across all diseases, including unattended deaths. In fact, these are examples of the Sustainable Development Goals, no? Which is an attempt to evolve from the vertical Millennium Development Goals that we used to strive for in the past. The Philippine Primary Care Studies tried to identify some of these horizontal performance measures. We had outcomes for patients, healthcare worker outcomes, and administrative outcomes. Some of the patient outcomes were primary care benefit utilization. Ginagamit ba nila yung kanilang benefits? Out-of-pocket expenses. Did it go down? Nabawasan ba yung gastos na galing sa sariling bulsa? Patient satisfaction. No? Natuwa ba sila sa health services na naibigay sa kanila? And patient health. Were they healthier? Were they hospitalized less? Did they suffer less diseases? We also had healthcare worker outcomes. like healthcare worker knowledge. Alam ba nila ang dapat gawin? Ito I'd like to show you. No? This is the number of times they used the up-to-date software during their clinic. Between 2,000 and 3,000 times in each of our sites. This is very useful because this represents potentially averted consults with specialists. So patients were spared having to go somewhere else. In addition, we monitored healthcare worker satisfaction. Masaya ba sila? Do they plan to stay o mag-aalisan din ba? Were they happy with the electronic health records? Did this make things easier for them or lalo bang humirap? And were they rendering good quality care? Let me show you some data on that. No? Diabetic patients are supposed to undergo a test called HbA1c every 3 months. So we tried to count how many had it even once a year. In our rural area and in our GIDA, it was very low, 16 and 29% respectively. This has to be done more because this is part of high quality care that we need to give our patients. Another measure was the number of patients with respiratory tract infection who are given antibiotics too early. If you're having cough or cold less than 4 days, it's probably viral, so you don't need to be given antibiotics. And we tried to count how often this was happening. Masyadong mataas in our rural area. Almost 80% of patients were being given antibiotics too early. Much better in the isolated area where only 10% were given antibiotics too early. So this is just examples of quality of care measures that we can come up with very quickly when you have electronic health records as part of a health information system. Finally, we have administrative outcomes like cost, which I showed you. How much were we spending? And administrative efficiency. We were able to track how much we needed to pay and when we needed to pay various members of the healthcare provider network. So in summary, I've talked about the rationale for the universal healthcare law and talked about 6 issues in universal healthcare governance, and finally how the health information system helps us address these different governance issues. In particular, I talked about the role of the health information system in UHC governance through workforce development, and that's by developing a map of human resources and providing a venue for continuing education. For the healthcare provider network, the HIS develops a facility map, which should be done up to the barangay level, and helps us come up with an inventory of facilities. For financing, it helps us monitor our expenses and in that way monitor for abuse and even prevent fraud. It also helps us engage with the communities through patient education materials and access to patient communication, for example, through their cellular numbers. Finally, it helps us monitor performance measures, whether they pertain to patient outcomes, healthcare worker outcomes, or administrative outcomes, such as expenses and efficiency of payment. These are just some side benefits of the health information system. The main reason we use the health information system is this. It's to improve patient care. I hope this helps us understand that actually we are taking care of 2 things. We're not just taking care of patients, we're also taking care of an entire healthcare system. Let's not forget that these are just potential benefits of the health information system, because there are going to be many problems in implementing it, and that will be the topic of my next talk, which is problems and potential solutions in developing health information systems as we try to implement universal healthcare. Thank you for your attention.